All right, thanks a lot for submitting the results to the poll. I think we should start. It's about 8:05, and we want to keep it to about an hour or so, and then everyone can have a good rest tonight. So without further ado, I think I'll hand over to the stage to Dr. Soma Subramaniam, who's the president of the ASEAN Rhinologic Society. Soma, please.
Thanks for putting together this first rhinoplasty webinar. So how this started was during the previous AGM of the society, we thought up of the idea of starting a rhinoplasty section, because I think a lot of us are actually doing some, and there's a lot of interest in learning new techniques, and there's a lot of value in adding this within the society. So thanks for organizing this. We're very honored to have Dr. Rival and Dr. Yap as well to give us invaluable insights into their practice in rhinoplasty. So Julip, thanks for putting this program together, and I'll hand it back to you. Thank you.
Thank you, Soma. All right, so okay. So now, yeah, thanks again for coming in and for joining us. I think we have a decent attendance tonight, so that's great. I'm Julip. A little bit of introduction. I chair the rhinoplasty section in the ASEAN Rhinologic Society. I do rhinoplasties, facial plastic surgery, as well as general ENT, in the National University Health System, in the Tik Fong Hospital. And we are very, very privileged to have two excellent, really excellent rhinoplasty surgeons with us tonight. We want to keep this webinar, the purpose of this webinar is really to have surgeons from different parts of the world, as well as from Asia and ASEAN, share their experience and knowledge with every one of us here in Southeast Asia. We may not be able to go to many conferences a year because of work, and all that, but technology has made it possible for us to learn from everyone else from across the world, through Zoom, or teleconferencing. So that's great. So without further ado, I will introduce our first speaker, Dr. Rival. Dr. Rival is a very senior rhinoplasty and facial plastic surgeon from Toronto, Canada. He was one of my fellowship mentors when I was doing a fellowship in Toronto, and he's one of the best rhinoplasty surgeons that I know of. I learned a lot from him, and he graduated from the University of Toronto with honors, and focuses a lot of his practice on facial plastics, and in particular rhinoplasty. He was the past president of the Canadian Academy of Facial Plastic Surgery, and he runs a very successful fellowship program, and also an annual instructional course for other surgeons, with a focus on rhinoplasty. So, Dr. Rival, thanks for joining us. I know it's like 7 a.m. in Toronto, and you have a surgery to start, in an hour or so. So, thanks for joining us, and we look forward to your talk. Thank you.
Thank you so much. Thank you so much, Chu. It's really an honor to be able to speak at your inaugural webinar. And I'm just going to share my screen here. And let me just, okay. And is everyone seeing this okay?
Yes, we can see it. Yep.
Okay, great. Well, thanks again. I really appreciate you inviting me. And as Chu said, I'm in Toronto, Canada. We just had our first snowstorm, and it's about 7 in the morning. So I know most of you are in the evening and before your bedtime. So I really appreciate you guys coming out. I'm going to talk about a topic that is not so technique related, but I think is very important. And for whatever surgery you do, this is focused on rhinoplasty, but really I think some of these lessons are valuable for anyone who does surgery on human beings. So I have no disclosures. So in Canada, we have this doctor's rating system called Rate MDs, where patients can go on express their opinions. And I'm sure you have the same there. But so this was a few years back. I opened my Rate MD page and I saw this nice review. It said, "Destroyers of lives, took a perfectly decent looking nose and made it look like it had been slammed against a wall. He plays God, choosing who he will help and whom he'll destroy. He makes a mockery of the Hippocratic Oath. My life is over. The opportunity for love in life has vanished. The chance of success destroyed. He only thinks of himself, hates the poor, has no sympathy for men. He uses your innocent trust for profit and delights as he rips your life to pieces, smirking as you struggle to come to terms with the reality of what's happened to you and the hopelessness of your now permanent situation. He humiliates you, he returns to him devastated and confused." Anyway, you can read the rest there. Very well written, I gotta admit. So that was one day, and then the next day, he wrote another review. It's a goddamn animal, should be burned for his transgressions. I went in needing a minor septoplasty, which is covered by OHIP. OHIP's the government health insurance here in Ontario, Canada. The structure of the appearance of the nose was fine, but there was minor issues with breathing. He agreed to help and threw in a turbinectomy. He stated the only side effect may be some minor crusting. Didn't mention that the nose would become deformed and problems with the eyes and focus. He was top of my class and headed for a doctorate. Now people just see me as an ugly lug. And again, you can read the rest of it there. And then the next day, another one. Richard Rival destroyed my face. I had a life. People liked me. I had a potential future. He destroyed my face, and now I can't even stand the sight of myself. He mocked me when I returned to his office, devastated. Either he's going to die, I'm going to die, or we're both going to die. He'll either finish the job he started and just kill me already, or I'll drag him to hell with me. God knows it would probably cost him less to hire a hitman than it would to just fix the life he destroyed. So this one particularly disturbed me when there was death threats and that kind of thing. And yeah, the thought of a hitman did cross my mind. But in any event, if you've dealt with patients like this, you'd recognize this language as being very characteristic of body dysmorphic disorder. The very dramatic, the lack of self-worth, the ugliness, I'm a monster. These kind of things are very characteristic of body dysmorphic disorder. And this was a guy, actually, as I recognized who it was. This was a guy I just performed a very simple septoplasty on purely for breathing. I didn't do any aesthetic work at all, and his nose looked completely the same. He had absolutely no aesthetic change. But in his mind, I had caused this issue for him, and it is a lesson, I think, when we're doing functional surgery. We don't always have our guard up for this kind of thing. When we're doing cosmetic surgery, we're very focused. We're thinking about these things. But this was a purely functional case. I didn't probably even spend any time at all with the mental illness side of things, and paid a price for that. So I think that, we spend most of our times as surgeons focusing on, surgery and what techniques should we use? It's preservation, structural, open, closed, ultrasonic, rib graft, ear graft, all the various things that we really focus, and that's where our mind is most of the time. But as you get on in practice, and I've been doing this more than 30 years, I really focus more on patient selection. Who should I operate on? Because that really ends up being the most important thing in whether your patient is happy or not. It doesn't really matter what you do, what your result is. You have to choose your patient carefully, because you will. You can't make some people happy, and that will lead to a lot of stress for you. So I think patient selection becomes more and more important, and it's something that we all really need to focus on. The historical aspects to this in the 1940s and 50s, and pretty much anyone who had cosmetic surgery was thought to have some sort of underlying psychiatric disorder. And then we progressed to the point in the 90s where there was really, and everyone could have cosmetic surgery. There's really no poor candidates. The show Extreme Makeover in the 2000s made cosmetic surgery extremely popular, made it more accepted, and people just became aware of it. And now here we are in the 2016 with a very popular show, Botched. So which is scaring people away from cosmetic surgery. So we go back and forth with this. As surgeons, we have the ability to improve somebody's self-esteem or their self-worth, but we don't have the ability to improve patients who feel they're worthless because of their deformity. Most of these patients have had some kind of severe childhood trauma that they have, as children, blamed on themselves. And when they still feel worthless after their even a successful surgery, this can trigger this past trauma, and often the surgeon becomes the perpetrator or the abuser. So the transference occurs from their past trauma to you, and so we have to be quite thinking about this and aware. We need to sort out who's going to be happy or ecstatic with their results and who will be unhappy no matter how excellent the improvement. And more worrisome is who may be a danger to themselves or to us, in fact, after surgery. There are several cases, I know of 3 at least, rhinoplasty surgeons who were murdered by their patients internationally. So it can be a dangerous business that we're in. Generally, though, most of our patients are somewhere in the middle. They're not the extremes, and we tend to pick out the extremes, but we have trouble sometimes, finding people that are somewhere in the middle. Most of us kind of use our sixth sense or trust your instincts or blink type of approach. I was always told never operate on someone you don't like, don't operate on someone you wouldn't be friends with. But as it turns out, if you look at the psychologic evaluations of patients that undergo rhinoplasty or present for rhinoplasty, about 30% of them have some degree of BDD. But if you ask surgeons, they will only say there's about 2% of patients that have BDD. So we're definitely not using our gut is not the only thing that is going to work. We're not great at detecting the non-extreme versions of these issues. Dr. Mark Constantian talks about it being in the eyes. That these patients have a look in their eyes that are sort of a cold, distant look that you need to look out for. And so I took some of my most unhappy patients and took a shot of their eyes. And yeah, I think a lot of them do have that kind of cold, distant look without any kind of emotion. So I think there may be something to that, but it's kind of a soft finding. And there's patient factors, and that's what I'm going to focus on. But there's also surgeon factors that we have to think about. I think a lot of surgeons fall into the either cowboys where they'll operate on everybody and anyone who shows up in their office versus the more other extreme surgeons that are almost too careful and won't operate on anybody. And again, most of us are somewhere in the middle. There's a financial motivation to aesthetic surgery. There's an ego motivation that we're always fighting against. Most of us have pretty big egos, and I think the one mistake we sometimes make is that we think that our surgical skill can overcome the psychology of the patient. We're doctors. We want to help people. We want to make them better. But we can't repair damaged psychology with surgery. I think every cosmetic surgeon would benefit from psychotherapy themselves. I think it's something that will help you in terms of at least understanding yourself, why you react the way you do, how you interact with patients, and help you understand your patients as well. So we all could use it. So body dysmorphic disorder has been defined by the DSM-5 as a preoccupation with a perceived defect in physical appearance that's not observable or appears slight to others. Um, this would uh, describe most of our patients, I think, especially the postoperative ones. And they often have repetitive acts or behaviors like mirror checking, grooming, skin picking. But the most important thing is that they have clinically significant distress or impairment in social, occupational, or other areas of functioning as a result of their perceived defect in their physical appearance. So that's really the key to this, is like how it affects their lives. Like most of our patients are obsessed with a physical appearance issue. That's why they're there to see us, but it's how it affects them, how it affects their self-worth, what kind of language they use to describe it, whether they can still work, have a job, have a relationship, and function in society. Patients that have severe BDD really can't function because of their disorder. The WHO classification more recently recognizes two subcategories, one with fair to good insight and one without any insight. And it seems to be overall a spectrum of symptoms ranging from mild, moderate to severe. And patients usually fall somewhere along the spectrum. And it's been my experience that patients that have mild symptoms, that have some insight into it, that have had therapy, that may be on medication, can still do quite well. And as long as you can see the defect and or the issue, and you feel like you can deal with them. So I have operated on patients with BDD, but it has to be patients that fall into this category, patients that have had counseling, that are aware of it, that have insight into it. But patients that are not in that category, I think that generally we have to stay away from them, because surgery can, as I say, reignite the trauma that they're going through. Personality disorders, we have to be aware and look out for these personality disorders. Obsessive compulsive personality disorder, they tend to obsess over trivial regularities, both before and after surgery. Again, it's a matter, a lot of us have some degree of OCD, but it's a matter of how it affects their life, how severe it is. Narcissistic personality disorder, whether they tend to be very self-important, grandiose, they don't follow instructions, and the sine qua non, I think, of this issue is that they'll be very nice to you, they'll treat you very well, but they'll treat your staff terribly, they'll be rude to your staff, they'll be very difficult. So if you're hearing that from your staff, you really have to think that that might be dealing with someone like that. Borderline disorder, personality disorder, they tend to split things into either very good or very bad. You can go very quickly from being the hero to a villain. There's a high rate of depression, suicide attempts. This is the type of patient who comes in and says, "Doctor, you're the only one who can fix me. You can save me. You're gonna fix my life. I know you can do it. You're the best." Excessively praising you. And so, of course, as surgeons, we like that. It goes to our ego, and we think, yes, I am the one who can save you. But that really should be a red flag for you, and not to be careful and to look into these patients more carefully. I really love this graph. I think it compares the patient's concern versus the degree of deformity. I think that we should try to stay in the green area most of the time, especially when you're starting out in your first 5 to 10 years of practice. You should really just focus on patients that have big deformities, minor concern. Those patients, you're going to make them happy almost every time. As you get more experience, more confident, you may want to take on patients that have more minor deformities. But I think we try to stay in the green area as much as you can. This is a mnemonic that I think we're all taught in studying for exams, the Simon mnemonic. I don't know that it's something that I particularly use or believe in. We're supposed to stay away from people that are single, immature, male, overly expectant, narcissistic. I mean, most of our patients are single and immature that we do rhinoplasty on. They're young women generally. And we can't really say that all males are we should stay away from. I think that's the wrong way to think about it. But it's something to know for exams versus the green flag type of patient, which they use the mnemonic Sylvia. Secure, young, listens, verbal, intelligent, attractive. Again, these are just very generic things that I think are more useful for exams than real life. My approach is to, really focus in on the history, use computer imaging in every case, self-reporting screening tools, using your mental health professionals as a referral source. And then using repeat visits. Everyone can have a bad day, so I think it's important to bring them back and see them a few times if you're not sure. So in the history, you want to focus on their concern about the deformity. How many times a day do they think about it? How does this satisfaction disrupt their life? What's their motivation for surgery? Why do they want to do it? Particularly in an older patient, why now? I ask that question all the time. How do you think your life will change if you have this surgery? Like you'll get answers like, people will love me again, or I won't be ugly, or I'll be able to get a better job. So I mean those are kind of answers should concern you. Most patients will say, yeah, I'll be able to not think about my nose as much, and I'll be able to take photos and not be worried how I look in photos, and just feel better. And those are normal answers that every patient that pursues rhinoplasty will have. But when it's sort of their whole life depends on it, and they use very language that's very extreme, I think you got to explore that. In Canada and in North America, I would say about 80% of my patients are on some sort of SSRI medication, and so it's kind of routine, and most of the time they're taking it for depression or anxiety. And I think it's important to explore that. Like, how long have you been on the medication? Is it working? Tell me about your anxiety, how it affects you. You want to get into it a bit, and it's important to explore that. Previous procedures, have they had previous surgeries? How do they respond? What do they think of their results? Explore that with them. You can get a good feel for how they interacted with their previous surgeon. And computer imaging for me is key. It's not so much, again, about showing what the outcome is going to be. It's more about getting their reaction to see if you can make them happy. You show them a result that's what you're thinking, and see if they like what they see. If they don't like what they see, and you can't make them happy during your computer imaging session, and you're happy what you can show, then I think this is, again, a red flag, and I really don't try not to operate on any patients that aren't happy with their computer imaging. You'll have patients that will email you, can you change this? Can you change that? To some degree that's normal, but when you're getting multiple requests to change this, can you do a little more of this, a little more of that? Over focus on these computer imaging is also something that is a sign that you should potentially avoid that patient. I do use questionnaires, the BDDQ aesthetic surgery questionnaire, the Utrecht questionnaire, the SCHNOZ. These are common, patient assessment tools that we use that can be helpful for screening. The BDDQ aesthetic surgery questionnaire really focuses on the degree of concern of the deformity. The Utrecht as well. I use the SCHNOZ because it's an overall assessment of their nose, both from function, appearance, and as particularly question 5, you want to look at their decreased mood and self-esteem due to their nose. And if you're seeing that everything is a 4 or a 5, then again, it should prompt you to do more exploration, and focus more on the history, and potentially have counseling. So in general, if you don't operate on someone if you don't like them, again, that's a general statement. If they ask for something you can't deliver, something that's outside of your aesthetic sense, if they're critical of their previous surgeons or they praise you excessively, if they're rude to you or your staff, if they give you false information, they refuse to be examined, they refuse to have photographs, if they're perfectionistic or want a guarantee of a result, or if they're blatantly paranoid, delusional, depressed, or have severe PDD. Sometimes it's better not to reject right away. Although if you're sure that you're not going to operate on them, I do think it is better to just lay it out for them. But sometimes, people can be going through things and maybe just having a bad day, and it's better to bring them back, do some more exploration, get referred to your local mental health professional, and go from there. If you do have someone who's defensive, or sorry, who's not happy with their outcome, the natural response is to become defensive. But it's totally the wrong thing to do. You want to not get excited, don't get insulted, don't get angry, don't say things like, "I told you this could happen," or we discussed this before the surgery. You want to use reflective listening. The patient wants to be heard. You have to say things like, "It sounds like you're saying," reflect back to them what they're saying. "I think it seems like what's bothering you is this," or "if I could summarize what I'm hearing," or "hear what you're saying." Just reflect back to them so they understand that what's going on. And then after letting them know that you hear them, would it be reasonable to suggest some possible solutions? So, and again, thank you so much for inviting me. I really appreciate the opportunity. And I take any questions in the chat.
Thanks a lot, Dr. Rival. Thank you for
my pleasure.
It's really, really insightful talk. And I remember when, as I was having training, we always were taught that, when you first start out, you know that you want to do surgery and you do everything. And as you get more and more seasoned and experience, you know what not to operate on, when not to do surgery. And I think, this is something that applies to all of us. And there are many in the audience who may be currently doing functional surgery and are thinking of going into aesthetic surgery. It's a totally different game, and I think this talk really sets the stage on, sort of making a decision on whether to move on to aesthetic surgery, or if you're already doing aesthetic surgery, I think there are a lot of things that we can learn from this talk. I think, okay, we have one question. Does computer imaging raise patients' expectations? Could it lead to potential dissatisfaction or blame towards a surgeon if the results do not match the projected outcome displayed during imaging?
Yeah, I mean, I think it's always a possibility, but in my experience, it's very rare. You can use a disclaimer, obviously, whenever you provide computer imaging, and most people understand that it's just a computer image. It's not a guarantee of an actual result. And so, yeah, that will happen, but it's fairly rare. Like I can think of that happening once or twice in my 30 years, of someone who actually said, "Well, you said you could give me this and I got this." It's really rare. And so I think the benefits definitely outweigh the downside of using it. Yeah.
And I remember you emailed them the imaging, right?
Yeah, I send it to them. They like that. They want something to look at from the consultation, and again, I really haven't had any issues from that. I think people do understand that it's not a guarantee of a result. Yeah, some surgeons don't want to share the image, and some surgeons don't want to do imaging altogether. But I do it for myself as much as for the patient, and I really find it essential. I can't operate on someone if I haven't done it. I just need to get their reaction to see if we're on the same page.
Right. I do it as well, and I share it with patients. But I find that you have to, especially when you first start out, you got to know what you can achieve, because you can shape an ideal nose, but you may not be able to achieve that. So I think it's important that you know what. I mean, as a surgeon, you must know what you can achieve, and then you do it on the
Yeah, that's very true. Yeah, very true.
Okay, right. WhatsApp group. Okay. So do you have any other questions? So I think there's one on the administration thing, so that's okay. Any other questions for Dr. Rai? If not, yep. Thanks a lot. Thank you very much.
Thank you so much. Thank you so much.
Yeah, I know you have to sign off now, right? Or soon, because you know, you gotta head out to surgery.
Yeah, I'll try to stay on my phone on the way to work, but so I really would like to see the next presentation as well. But thank you so much.
Thank you, Dr. Rai. We'll hope to see you
Have a good day, guys.
sometime.
Hope to see you soon.
Yeah. All right. Bye-bye. Thank you.
Bye now. Bye.
All right. Yep. So after Dr. Rival's very, very insightful talk, we now have another very esteemed surgeon from our region, Dr. Eduardo Yap from Philippines. I think many of us know Dr. Yap, and you know he is you know, very well known surgeon who's very committed to rhinoplasty and runs a fellowship program and has taught many renowned surgeons, now renowned surgeons in Philippines and in Asia. He also runs a very, very successful course called Rhino Mama in Manila. So just doing an advertisement for Dr. Yap. If you, you know, you can always look out for that course. I think it is very, very well received and has run for many years already. And one of Dr. Yap's, you know, specialty, special technique really is on the ala, which is something that Asian surgeons, especially in Southeast Asia, have a problem with because we have broad and generally thick ala, which is not really considered very aesthetic. So, you know, and Dr. Yap has an excellent technique that is tailored specifically for the Asian nose and specifically for the Southeast Asian nose. So, without further ado, I'll hand the stage over to Dr. Yap. Thank you, Dr. Yap.
Yes, thank you very much, Professor Nang Chulip. Thank you very much, and for this opportunity also, I would like to share my technique in making our Asian ala better looking. And for me, I call this the wow effect in your rhinoplasty. So wow effect for me is something that makes your nose good looking. However, patient cannot really see that, no? Wait, give me a minute. Can you see my slides?
Yep, we can.
Okay, so I call this the scale excision for modification of alar morphology. As you will see, as you would notice, most Asian noses, we have a globular ala, and we have also a hanging ala, a thick ala, and the ala-columella relationship is not really that ideal looking. Okay, so okay, next slide. Okay, so when we look at the ala, we see usually the alar rim. This is a good alar rim. You have gull swing on flight. That's good. Okay, we have alar flare. That's another way of us looking at the ala. And then we have the alar seal, this one here, the width at the floor. So one of the aesthetic deformity in Asian noses, especially the Southeast Asian nose, are the wide ala, a globular ala, and there is also another aspect in our rhinoplasty is that we have a globular ala. This is really round looking. Okay, so this is a typical Southeast Asian Malay nose. You can see she's quite pretty, but the nose, it's quite okay, but we can still make it prettier. And I find this a very good technique in lifting the alar rim at the same time, correcting the globular ala, and at the same time, it raises up our alar rim base. Normally, our alar rim base should be a bit higher than your columellar base. So I call this a sail because this looks like a sail of a sailboat. So firstly, you have to locate point A. point A. Later, I'll show you how to locate that. And then point B. So apex, that's also the apex. And then you can also see a groove here. Do not mistake this as the caudal margin of your lower lateral cartilage. By the way, you have several clue as to detect this one. Firstly, you have a groove, and then you have a clear demarcation of a thin hair and thick hair. And then later, I'll show you a picture that you can see a trans-illuminated ala, because this part here doesn't contain any cartilage. So determining point A, point B, and the vestibular groove. By the way, the vestibular groove goes inferior, posterior, from point A down to the vestibule mucosal junction. Okay, and then connect all of them. So this is like a irregular triangle, but this is something like an ellipse. So this is a transillumination in a sail. You can see very well. So these maneuvers are used to confirm your the defect that you will correct, that you will take out. So again, do not mistake the groove to the lower lateral cartilage margin here. And one thing I noticed is that this groove here is always parallel to your caudal margin of the lower lateral cartilage. If it is not parallel, then this is possibly not the groove. But I tell you, everybody has this groove. This groove is deeper in patient with hanging ala, in patient with severely globular ala. You can see this groove is really deep inside. Now, for a patient with a very nice alar, especially in Caucasian nose, you will see the groove is almost at the edge. You can almost never see the sail part here. So the groove is actually a depression in the nostril vestibular area. You have hair in this part. This part here has hair or thinner hair, sometimes no hair at all. Now, this depression here is due to the different orientation of the nasalis muscle. So the essence here is you do a full thickness cut all the way. The dissection is at the fat layer of the skin. And then you come out here at the rim or the medial side of the alar rim. So this is the maneuver that you do. Simple, you just have to press. And when you do this, you can see a notch here. And this maneuver, by pressing the ala, columella to the ala, also confirm your vestibular groove. This is discovered by Dr. Homer Matias. This guy here, he is my pioneer fellow way back 2006. Okay, he's doing good in Davao, Mindanao, south of the Philippines. So this is point A. Now point B is this one. If you press your alar down, you can see again a notch here. Okay, so this is point A, point B. So by determining the 2 points, point A and point B, okay, then locate the groove and then connect point A and B at the medial side of the alar rim, and then connect point B to the end of the junction. And then make no sharp corners, by the way. When you design both, better check for the symmetry, better check that the the width are equal. Now, when you take them out, the cut is a full layer cut, and the excision is a full layer excision. The plane of dissection is the fat layer of the skin outside. So the essence here is you want the skin to roll in. Okay, may I pause this for a while? Okay. So the technique here is you remove a full layer thickness of the elliptical tissue that you have taken out. No need for cautery. Please do not cautery because I have seen I never use cautery here. If there are bleeding, you just suture it and it will stop by tamponade. Okay. Now, the first suture that you will do is suturing point B to where it corresponds. Okay? So it's just like a rule in any plastic surgery. If it is an elliptical deformity, so the closure is parallel to each line. So align first this point B, skin to the other end. So this essentially lift up the alar rim. Your alar rim is pulled up. And what happened here, the skin is rolled inside. Therefore, the new alar rim is lined by skin. The other technique in lifting the alar rim is an external cut, which is done at the end of the procedure. By the way, the sail excision should be done at the start of surgery. Do not do this at the last part. Results will never be good. And the landmark, you might have difficulty in doing the Matias maneuver and all the maneuver that you need to elicit point A and point B. So please do it at the first part. I use Vicryl 6.0 here, and you can just close it simple, interrupted, or continuous. So by doing this, you can see there's an immediate lift of the alar rim base versus the columellar base. This is an aesthetic advancement. And you can see the immediate effect of the gull swing on flight. So nothing yet was done on the nose. So if you would like to consider the sail excision, please do it at the first part. Okay? Actually, in about 98 out of 100 of all Asian patients that I operate, there is a need of removal of a piece of this elliptical tissue. I do sail excision in almost all of my Asian patients. Okay, so commonly we encounter a nose like this pre-op. This is post-op, so I have to do a sail first, and then the actual rhinoplasty. I structured rhinoplasty. I do a full structured rhinoplasty, usually a combination of a septal extension graft and a extended spreader graft. Okay, and if you would notice, later I have slides to show you the improvement in all dimensions of the ALA. So this is pre-op and immediately post-op. You can see a difference, no? So this is a patient pre-op. This is a patient immediately post-op. So pre-op, immediately post-op, what can you see? There is a significant decrease in the height. So the globular shape of the ALA is also reduced. It's not a globular shape anymore. It is a ridge shape, which is more appealing. And of course, after a structured rhinoplasty and some tip modification surgery, you would notice that the height is lower, and this makes the tip less bulbous. So this is the gull swing pre-op. This is the gull swing post-op. So on a quarter view, you see the height is lesser. Obviously, the hanging ala is corrected. Okay. Notice also the alar rim base. It is a bit higher than the columellar base. This is pre-op. immediate post-op. Again, the height is decreased. There is a shift of the general morphology, the shape of the ala, from a globular shape to an oval shape. This is overall after a full structured rhinoplasty. So hanging ala, a globular ala to an oval shape, alar ridge. You can see the light reflex. It's now longer. And this one goes exactly where your tip should be. So this is a thick alar rim. You can actually extend your sail excision a little outward. Your landmark here is, this is your landmark. You can mark it here. The thickness here should be here. Your extension of your sail should not be more than this part probably. And you can also reduce. This is exactly the patient, reduce the alar width. The thickness, rather, thickness. So another patient, you can see the alar rim base. This is pre-op and this is post-op. So check the alar rim base. Now, the same patient undergoing tip projection surgery and dorsal augmentation without any alar lift or alar modification surgery, the patient looks better, but with the sail excision and making the alar morphology better looking, there is this advantage. I tell you, patients, even doctors, they don't see this. They will just say the rhinoplasty is more elegant if you do this sail excision. You cannot even see or trace any surgery that the patient has an alar lift because this scar is inside the rim. So this is the same patient, pre-op, post-op, 1 week after a full structured rhinoplasty with a dorsal implant and a sail excision. So you see obviously a hanging ala. This is a lot lower than the columellar base. Now it is more pleasant. The alar rim base is now higher than the columellar base. The shape of the ala is now more oval. And if you can trace the light reflex, it goes up here straight and it gives an elegant look in your rhinoplasty. That's why I call this the wow effect in your rhinoplasty. So before and after. Before and after. Okay. Most often, you have a hidden scar along the rim. And patient, they don't see a trace that they had this surgery done unless you show photos that your alar rim is lifted, your globular alar is made better. Patients sometimes, usually they don't notice that. Now, some undesirable effects. Asymmetry may happen. Probably you may be a little bit more aggressive on one side. Again, you have to check the landmarks. All these landmarks are constant. The point A, point B, alar rim, and the vestibular groove. They are all constant. Everybody has that. You just have to follow them. Okay? If you follow them, it is almost always symmetrical and you are almost always correct. Now, you might have a patient with a thick ala post-op. A thickened ala, probably it is because of conservative excision. When you excise, again, it should be a full skin from inside out, skin, subcu, muscle, and subcutaneous of the skin just beneath here. Okay, so essentially, this is a skin flap that you roll inside into the vestibule. You may have a thickened scar. Thickened scar may mean that it may, for me, this is iatrogenic. Okay, but always tell patients that this is a hypertrophic scar. we can easily correct that. Okay, so how do you correct this? By doing a elliptical excision of the thickened scar. Just make it symmetrical. Okay, and by doing that, there is this added lift, which is also good looking post-op. So sail excision, therefore, sail excision does not only address the hanging ala, but can also change the alar lobule morphology. Reduction of the nasal alar vertical height. You can see a reduction. You can see the reorientation of the alar rim. By the way, in doing the sail excision, I noticed there is this counter rotation effect, illusion of a counter rotation of our tip. So why? Because the alar rim base is made higher than the columellar base. And that gives you an illusion of a counter rotation. And there is a change in the alar rim thickness. Now, alar rim thickness. You can just remove the more fats than usual, and you can see when you close them, it is thinner than usual. And the change in the overall lobule shape was evident immediately post-op. The morphology changed from a globular hanging ala to a thin alar ridge. Again, this is more aesthetically pleasing. And here, again, alar rim base is now higher than the columellar base. This was initially reported year 2010, and through the years, I modified and a new a new report article is published now in our journal. You can search internet. This is free for download. Just search sail excision, alar morphology, or Asian noses, and this article will pop up. Download this, and all the photos in my slide are there, and it's clearly specified as to where you cut, how to cut, and how to suture. So my advice here again is do this at the first part of your rhinoplasty. Never apply this at the last part of your surgery. If you have alar, hanging alar or a globular alar post-op, please do the other technique. It is the external cut. That is very the external cut is not that accurate because you don't have landmarks to follow. So it's more of experience. There are many surgeons in our country. They do the external alar lift, which are really very good. However, the scars are here outside. However, this scar heals very well, heals very nice. Okay, so I think this is my last slide. Okay, so thank you very much. So this is my technique, which I think is very applicable in our rhinoplasty. This is just an additional 30 to 40-minute surgery, and this will give you the wow effect in your rhinoplasty.
Thank you very
So
much, Dr.
I'm
Yap.
open for questions.
Thank you. Always good to hear your talks and your very
you.
detailed techniques. We have two Q&As. I also have some questions, but we'll answer the Q&As first. The first of all is actually the first question: what would you do if a patient has a body dysmorphic disorder coming for rhinoplasty after many surgeries? I think that is one question. The second one is the size of the point from the apex to the point B, from point A to point B, or the vestibular groove. Is there a standard size that you excise, or there's a variation? Can you excise less when you first start off, and then when you get more confident, you do a little bit more? Perhaps you want to answer this question first.
Okay, first, how I manage for patients with multiple surgery. Okay, first of all, when patients, okay, it's like this. Patient with rhinoplasty, most often than not, they forget how they look before. They don't have their old photos with them. So what happened is these patients have this notion in their mind that their noses are similar to something like a gadget that you can have version 2.0, then 2.1, then 2.12, something like that. Every now and then there can be an upgrade. So I have to correct the patient. I always tell them, do you have an old photo? Okay. If the patient doesn't have the old photo, then I have to check. If I see that there is no functional problem, just an aesthetic problem, I will try to see if there is still a way to improve. Because as you as everybody here knows, if you the more surgery you have, the problem with vascularity circulation is really a big problem after. Infection is also another one, even though we use the all autologous. So I try to avoid doing surgery on patients with multiple rhinoplasty surgery. That's one. So you have to ask the pre-op patient, the original nose. If you see improvement, then don't touch it anymore. Okay.
Okay.
Now, the other question is, as starting doing the sail excision. All right. First of all, don't go for any conservative cut. Point A is always point A. Point B is always point B. So when you press it, there is this point B. For your information, point B do not go through the nasal vestibule. It is not here. It is always at your side, point B. All right. So you just have to connect point A to point B, and then you just look for the YAPS group. That's very accurate. Now, how would you know that that how much removal that you need? First of all, if the ala is really very round, so you check, you can just draw an imaginary line from the rim, then out, it comes up. Now, if you see that the angle here to here is very acute, small, then it should be your drawing inside the sail excision should also be that approximately at that angle. Okay, so that is just one of my modification. But generally, just follow the groove, just follow point A, point B, everything will come good. And before cutting, always compare the left and right drawing, and then when you cut them out, always compare the defect, always compare also the tissue that you have taken out, and then suture first point B to check symmetry of the alar lift. Yeah.
Okay, thank you. Next question, if a patient is highly prone to developing keloids, would you still, it says proceed with rhinoplasty, but I think probably the question is, would you still do the sail excision?
Okay, so, all right. To tell you honestly, even patients with keloid, I haven't seen one keloid in the nose. However, for me, I find that a good excuse. If the patient says, I am prone to keloid. Okay, keloid may happen in your ear. It may happen in your nose, but not common. Okay. So you still have to proceed because it makes the nose a lot good looking. The scar is actually inside. And for me, I haven't seen actual keloid inside, but I have seen a few hypertrophic scar. So if you have a patient with thick scar, so you can say, okay, so probably your healing is not really that at par with most average patients. And okay, we can do a little excision, or sometimes steroid injection is also good after surgery. Steroid.
Right. Thank you. I have two questions of my own. First of all, you mentioned that you do it at the start rather than at the end, which is completely the opposite of what we usually do for rhinoplasty, which is we do everything, and then the end of it, you look at how the alar looks like, and then you do the alar reduction. Part of the reason is because sometimes, when you stretch out, when you extend the tip, the projection, and the caudal septum, Then this part comes in as well as you project the tip. And then we make the we may need a little bit less of the alar reduction. What is your reason for doing the sail excision first?
Okay, so we have to check that there is actually the ala is like a box. It's like a box. We have a superior, inferior, lateral surface, something like that. So when you look at the ala, sort of we have three dimensions. First is the alar rim. Second, when you look at a patient with a wide nose, the nose appears wide. But under the width, when you see a wide ala, it has two things with it. It is either the flare, it flares too much out, that's one. Another is you have a too much width. This one is too wide. So the width and the flare is the reason for the wide-looking ala. All right, therefore, it's like this. For the ala, you have, especially for Asian noses, almost always we have to do an alar lift. Doing the alar lift corrects also the alar morphology. So that's 2 in 1. And then doing the alar plasty corrects the alar, the width of the ala and the shape, the lateral shape of the ala. Okay, now, so that is 2 procedures. The first procedure is the sail excision. For me, I should do it at the first part, because when the tip is up, you can see a nice ala columella. Almost always, the nose looks good already when the tip is projected and you have a nice gull swing on flight. Therefore, for me, do the sail at the first part, and then when the tip is up, and then that's the time that you see, that you check how much width that you want to improve. Most often than not, it is just a wedge excision of your alar flare. The width somehow narrows. Your foot plate is pulled up with your structured rhinoplasty. So the foot plate here comes up, and the previous nasal seal is now narrower. And for me, I don't think you need seal excision, seal, S-I-L-L, the floor excision. So most often than not, I ended up just doing a little wedge excision out here. So again, ALA, 2 separate procedure. Lift first the alar rim, correct first the alar, because doing sail excision will never cross the rhinoplasty. It will never cross the nasal seal. Therefore, many friends, colleagues, they said after doing a sail, they can't do anymore the wedge, rather the floor excision, the alar base. I told them probably you did not follow the point A and point B. So now it's quite clear, and I like all of us here to try this. This gives you an edge in your rhinoplasty aesthetic effect.
Okay, thank you, Dr. Yap. One last question for me. After you do the sail excision, how do you connect your incisions, or do you even connect the incisions to the with the alar, the external alar cuts and the marginal incision inside?
Okay, the two should never meet. The two should never meet. So the alar rim, the margin of the ala should not be for me, no incision should go through inside. Okay, to make the ala good looking, except if you will excise the nasal seal. Again, when you excise the nasal seal, it is away, it is more medial than the sail excision defect. So I think you still have around 3 mm from the sail excision. Therefore, it is very safe in really a very wide nose. Now, when you do your wedge, I stop here at the lateral portion. When I cut, I do not cut it way to the inside part of the ala, because sometimes the alar rim may lead to scarring. So I don't have any, when I do the wedge, it ends here, just a little lateral, inferior lateral.
Okay, I understand.
Yeah.
Thanks a lot for answering the questions. I think they're very clear.
Thank you. Thank you.
I think many of us would look forward to trying your technique and seeing how it goes. Yeah, but thank you very much. I think the results are very nice, and it's really something that we have a lot of problems with in Southeast Asia. Yep. So, all right. So I think it's 9:11, so it's about an hour. Thanks everyone.
Thank you. Thank you. Thank you for listening.
Yeah, thank you, Dr. Yap, for your very insightful talk. We really appreciate your time with us. And yep, so we have some advertisements. One would be next year in April. We're having the Singapore ENT Congress in conjunction with the annual scientific meeting of the ASEAN Rhinologic Society. So do join us. It's going to be multiple tracks over several days. There will be some endoscopic ear workshop. There will be ultrasound and thyroid radiofrequency ablation workshop, and there's going to be a FAST workshop as well. So do join us next year in Singapore. And also to sell some advertisement again. The ASEAN Rhinologic Society is a society that that is for Southeast Asian surgeons, but we welcome anyone from around the world, friends, to join us. Membership is extremely low priced, and and there are many webinars, and other educational activities that we can all join. So if you're interested in the nose, if you're interested in rhinoplasty, rhinology, skull-based surgery, and all that, please join us at the as a member of the ASEAN Rhinologic Society. All right. Thank you very much, everyone, for your time. Soma, do you want to anything that you want to add on?
Julep, thank you very much for spending your evening putting this webinar together. And I think it's benefited a lot of people who have attended tonight's event. Two wonderful speakers, very different themes. One more on a technical theme, and the other one more in terms of the thought process. So Chulip is the chair of the rhinoplasty section. So you can look forward to more of these events over 2025 and the future years following that. So Chulip, thank you very much. I think we can close the session. So thanks very much. Yes.
Thank you. Thanks, everyone. We'll try to have one once every quarter. So we look forward to seeing you guys again. Thank you. All right. Have a good night, everyone.
Good night, everyone. Thank you.
Bye-bye.
Bye-bye.